My name is Julia and I'll be presenting my pharmacology case study. Mr. Clark is a 68-year-old male who presented to the ED following an episode of speaking fragmented words. Assessments revealed the following signs and symptoms. Following further assessments and diagnostic tests, Mr. Clark was consequently diagnosed as having experienced an ischemic cerebrovascular accident and acute renal failure. I've outlined in this slide the clinical manifestations that point to each of these conditions. Acute renal failure has been linked with ischemic stroke, with many patients experiencing these conditions concurrently. Renal failure is often attributed to the prolonged use of certain medications. Mr. Clark is a retired engineer who lives alone and smokes and drinks heavily. He eats takeaway most nights each week and leads a sedentary lifestyle, rarely exercising. He has a BMI of 30 and is considered obese. His medical history includes coronary artery disease, type 2 diabetes, and osteoarthritis. Mr. Clark had a coronary artery bypass graft and a total knee arthroplasty. The demographics Mr. Clark has are also risk factors for his diagnosis. Let's delve into Mr. Clark's pre-admission medications. Amlodipine, an antihypertensive agent, a calcium channel blocker. He's likely been prescribed this to control CAD-associated hypertension and angina. This medication impedes the influx of calcium ions through slow channels of cell membrane during depolarization of cardiac and vascular smooth muscle. This improves myocardial O2 supply and cardiac output, reducing myocardial work by reducing afterload. It additionally dilates coronary and peripheral arteries, improving O2 supply and blood flow, ultimately reducing blood pressure. Amlodipine produces vasodilation due to its direct effect on vascular smooth muscle. As such, it may cause hypotension. Peripheral edema is a commonly reported side effect, thought to occur secondary to arteriolar dilatation, causing intracapillary hypertension and fluid extravasation. This edema is particularly undesirable in a CAD patient such as Mr. Clark, who already has cardiac compromise. Amlodipine may cause reflex tachycardia, which can increase myocardial oxygen demand, resulting in an exacerbation of angina. Extreme caution should be taken when using with beta blockers, as this may result in profound bradycardia, heart block, and hypotension. Increased vasodilation may also occur if given with nitrates, with this manifesting as hypotension with associated faintness and dizziness. Blood pressure and pulse monitoring, of course, should be persistently done before therapy and continually throughout. Patients should be advised not to cease therapy suddenly, as this can cause severe angina. Type 2 diabetics should monitor their BGLs closely during therapy because amlodipine interferes with glucose metabolism. Additionally, it inhibits calcium-mediated insulin release, leading to hypoglycemia. I've included here a visual of amlodipine's mechanism of action. Metformin, this is a hypoglycemic/anti-diabetic agent. It's a biguanide. It inhibits gluconeogenesis in the liver and glucose absorption from the GI tract and increases peripheral uptake and utilization in muscles by increasing insulin sensitivity. GI upset is a commonly reported adverse effect, may relate to local metformin concentrations in enterocytes, increased bile acid exposure in the colon, or an altered microbiome. Lactic acidosis is rare but potentially fatal. The pathophysiology of this occurring from metformin is likely due to inhibition of gluconeogenesis by blocking pyruvate carboxylase, which converts pyruvate to oxaloacetate. Blocking this enzyme leads to accumulation of lactic acid. Decreased B12 absorption may occur. The currently accepted explanation for this is the interference by metformin on calcium-dependent membrane action, responsible for B12 intrinsic factor absorption in the terminal ileum. Calcium channel blockers should be given with caution, as these agents affect BGL control. Metformin clearance can also be decreased if given with calcium channel blockers. The risk of lactic acidosis may be increased if given with alcohol or diuretics. This is fatal and manifests as nausea, vomiting, abdo pain, myalgia, diarrhea, malaise, hyperventilation, and decreased blood pH. Additionally, alcohol can delay or mask hypoglycemia symptoms. This is important for our patient as he is taking amlodipine and drinking alcohol. There are various patient monitoring points that are important whilst the patient is on metformin. These include, of course, rigorous BGL monitoring, regular liver and cardiovascular function monitoring, B12 levels at commencement 6 months then yearly, and serum levels before commencement yearly or more often if there is kidney impairment. The The patient should be advised to take metformin with meals to reduce the likelihood of a hypoglycemic episode or potential GI effects. Further, the patient should be educated on the signs and symptoms of lactic acidosis and hypoglycemic episodes, and to seek immediate medical care if they experience these. Panadol Osteo, which is 665 milligrams of modified release paracetamol, an analgesic and antipyretic. This has a central analgesic effect mediated through the activation of descending serotonergic pathways. Debate exists about the primary site of action, thought to be inhibition of prostaglandin synthesis. Can cause hepatic necrosis. This is through formation of the noxious NAPQI metabolite, which can lead to depletion in adenosine triphosphate. Renal dysfunction can occur. Like hepatic cells, renal microsomes can also oxidize paracetamol to a toxic byproduct. This indicates a biochemical mechanism of toxicity similar to that in the liver. Paracetamol can cause GI symptoms such as nausea and abdominal pain, but this is commonly dose-related. Other paracetamol-containing products should not be given together to avoid risk of overdose and hepatic damage. Metabolism may be increased by IV anticoagulants. This can thus increase the level of hepatotoxic metabolites. This overdose/hepatotoxic state may manifest as GI upset, elevation of liver enzymes, and jaundice. Pain levels should be assessed before and during therapy to determine effectiveness. Liver tests are recommended if an overdose is thought to have occurred, and then daily thereafter. And it's important that all routes are considered when calculating the total daily dose, which is 4 grams. The patient should be educated to be cautious of overdosing. Mr. Clark has now been commenced on post-admission medications, hydrocortisone, Clexane, and furosemide. Let's take a look at Clexane. This is enoxaparin sodium, an anticoagulant. It's a low molecular weight heparin that activates antithrombin, inhibiting generation of thrombin, as well as accelerating inhibition of factor XA. It's used to prevent venous thromboembolisms. Mr. Clark has likely been prescribed this medication both due to his stroke and whilst he is bedridden to prevent further embolisms. As enoxaparin impairs blood clot formation, the risk of bleeding/hemorrhage increases. Anemia can also occur, so although the precise molecular mechanisms are still unknown, it is thought that enoxaparin has the potential to decrease hemoglobin levels and induce anemia. Thrombocytopenia is this is a prothrombotic disorder caused by antibodies that attach to platelet factor 4, which induce platelet activation. Other drugs that affect hemostasis, such as NSAIDs, aspirin, other anticoagulant and antiplatelet agents, should be withdrawn before commencing therapy due to the increased risk of bleeding. Platelet count should be monitored before therapy commencement and during. If count falls to 30 to 50% of pre-therapy concentrations, drugs should be withdrawn. Patients should be monitored for and educated to report any signs of unusual bleeding/bruising, and they should be closely monitored for signs of spinal hematoma. Let's explore some changes that may occur in Mr. Clark's outpatient drug regime. He should continue amlodipine. This does not appear to have severe contraindications with his other medications, nor his current clinical picture. He may continue to use this to assist in controlling hypertension and angina. Additionally, as high blood pressure is a stroke risk factor, it's important to continue using antihypertensive therapies. Upon presenting to the ED, Mr. Clark had elevated liver enzymes. If this resolved without any long-term liver damage, Panadol Osteo can be continued at a low dose with caution. Though not ideal, it has been found to be one of the safer analgesics to take with liver impairment, safer than NSAIDs and opioids, which run the risk of further renal impairment, hepatorenal syndrome, and GI hemorrhage. He should cease hydrocortisone. This may have been prescribed to assist in reducing both cytotoxic and vasogenic edema, and has been known to improve the clinical outcomes after a stroke. Though it's valuable, it has a myriad of dangerous adverse effects and potential interactions, and is recommended to use for the least possible duration. Mr. Clark is likely to require a long-term anticoagulant due to his recent stroke, as it is possibly difficult for him to comply with enoxaparin injections at home. An oral anticoagulant such as apixaban may be feasible. This is used in stroke prophylaxis and does not appear to interact with his other medications. Mr. Clark may continue on furosemide as an oral form to assist with treating excessive fluid retention due to kidney impairment, and also assist with controlling hypertension. Metformin should be changed to a different hypoglycemic, as it is contraindicated in kidney disease due to the perceived risk of lactic acidosis. Glimepiride is a sulfonylurea that can be more safely prescribed. Also, considering his cholesterol levels, CAD and recent stroke, it's likely a lipid regulating agent may be added to his regime by the prescribing doctor, such as atorvastatin. If Mr. Clark is taking furosemide as an outpatient, he will require certain education on this. The following teachings should be discussed. Caution patient to change position slowly to minimize orthostatic hypotension. Instruct close monitoring of BGLs, as impaired glucose tolerance can occur. Advise of expected diuresis, so to take it early in the day to avoid nocturia. Advise the patient to ensure adequate hydration to prevent dehydration that can be caused by furosemide, taking into consideration, of course, any fluid restrictions. Educate the patient on the signs and symptoms of hypovolemia and electrolyte imbalances, and ensuring that they seek immediate medical advice if they notice any of these. Emphasize the importance of routine follow-up examinations, and advise the patient that furosemide helps relieve edema and controls blood pressure, and it is thus important to continue taking this even if they start to feel better. Thank you, and here are my references, both for my expanded information and in the PowerPoints.